The last topic for today is toxicity of fluoride. So I told the first unit that fluoride can be discussed under two headings in relation to dentistry. One is toxic effect at high concentrations and therapeutic effect at low concentration. So first we'll be talking about the toxicity. You must be familiar with this toxic effects of fluoride. You must have already read about fluorosis. So fluoride toxicity can be broadly classified into two categories. One is the acute fluoride toxicity and the second is chronic fluoride toxicity. The acute fluoride toxicity means it is a single ingestion of a large amount of fluoride at once. So it is single ingestion and there is a large quantity of fluoride that is consumed at a point of time. The main causes of acute fluoride toxicity are not natural causes. They are either accidental, homicidal or suicidal. So in relation to this, you need to understand two important dosages. One is called the safely tolerated dose. It is abbreviated as STD of fluoride, the safely tolerated dose, and the certainly lethal dose of fluoride. So the safely tolerated dose of fluoride ranges from 8 to 16 milligrams per kilogram body weight. Know this unit properly. It is 8 to 16 milligrams per kilogram body weight. So you have to multiply this along with the person's body weight to assume or to establish what is the safely tolerated dose of fluoride. The second is called the certainly lethal dose of fluoride. You must have heard about the term LD100 in pharmacology, that is the dose at which it is certainly lethal. So if a person consumes this dosage, the mortality is 100%. So that is why it is known as certainly lethal dose. Certainly lethal dose is also abbreviated as CLD. It is 4 times the safely tolerated dose. So the certainly lethal dose is 32 to 64 milligrams per kilogram body weight. Always pay attention to this unit. It is not just milligrams, it is milligram per kilogram body weight. Next, coming to what are the symptoms of acute fluoride toxicity. The most frequent symptom as soon as a person ingests fluoride, I've already told you in metabolism of fluoride, when there is acidity, what happens in stomach, you have the HCl. So when this HCl combines with fluoride, it results in the formation of hydrofluoric acid. And this hydrofluoric acid is a potential gastric irritant. Okay, so because fluoride is more electronegative than chlorine, this combination takes place readily. So it displaces chlorine and results in formation of hydrofluoric acid, and this is a gastric irritant, and hence the patient experiences nausea. That is the most frequent effect. The other symptoms are predominantly gastrointestinal symptoms. The gastrointestinal symptoms include nausea, as I told earlier. Then you have abdominal pain, abdominal cramps, all because of this gastric irritation. You have increased salivation, increased thirst, diarrhea, dehydration, vomiting, all related to each other. So basically the body will try to eliminate this fluoride, resulting in increased thirst because of diarrhea and increased dehydration and vomiting. So these are the initial gastrointestinal symptoms of acute fluoride poisoning. Then there are other systems also involved. The next is the neurological symptom. So this results in paresthesia, tetany, the depression of central nervous system, and can also result in coma. The cardiovascular symptoms include weak pulse, cardiovascular shock, and cardiac failure. The respiratory muscles, there is a paralysis of respiratory muscles, and when you take the blood picture, you can see there is acidosis, hypocalcemia, and hypomagnesemia. So these are the signs and symptoms other than gastrointestinal system, where it affects the neurological system, it affects the cardiovascular system, respiratory system, and also can change the blood picture. Coming to the prognosis, whenever the acute fluoride poisoning occurs, death usually occurs within the first 2 to 4 hours. And the main reason for death is either respiratory muscle paralysis or cardiac failure. I told about these two, the effect on cardiovascular system, effect on respiratory system. These are the two important causes that results in death of a patient due to acute fluoride toxicity, and if it usually occurs, it occurs within the first 2 to 4 hours. And it is generally said that if the patient survives for more than 24 hours, the prognosis is considered good. So that is regarding the prognosis following acute fluoride toxicity. Now, how do you manage this condition? The management of acute fluoride toxicity depends on the dose of fluoride ingested. So, when the dose can be calculated and if it is less than 5 milligrams per kg body weight, give calcium or milk. The reason I have told you in the previous unit, milk is an excellent inhibitor of absorption. So, whenever you give milk, the calcium present in milk can combine with fluoride to form calcium fluoride, and that reduces the absorption of fluoride. So that is the reason the most readily available calcium rich substance in our homes is the milk. So immediately give the patient milk so that it results in decreased absorption of fluoride into the body. And if possible, it's not very much necessary, or the patient might be feeling nauseating, and induced vomiting might not be necessary when the dosage is less than 5 milligrams per kg body weight. Next, when the dosage can be calculated between 5 to 15 milligrams per kg body weight, the first thing that has to be done is induce vomiting. Okay, give an emetic to induce vomiting. And if the patient has a depressed gag reflex, where the patient is maybe less than 6 months old, or the patient has Down syndrome or mental retardation, your induced vomiting is contraindicated, and instead you have to perform an endotracheal intubation. And instead of just milk, you can give orally soluble calcium, like you have 5% calcium gluconate solution or calcium lactate, which has higher amount of calcium. So instead of milk, you can give this because the dosage is a bit higher. And admit to the hospital, observe for a few hours. I told you the prognosis is good if the patient survives for the first 24 hours, and death usually occurs when it affects the cardiovascular and respiratory system. So there has to be constant monitoring, for which it is better to admit the patient to the hospital and keep him under observation. When the dosage is very high, that is more than 15 milligrams per kg body weight, admit to hospital immediately, induce vomiting, begin cardiac monitoring, administer 10% calcium gluconate solution intravenously. Okay, immediately administer 10% calcium gluconate solution intravenously. That is again to reduce absorption. Maintain the urine output and follow all supportive measures to prevent cardiovascular shock. So this is an emergency situation because the dosage is very high. All precautions have to be taken to prevent all the complications associated with the acute fluoride poisoning. So that is about acute fluoride toxicity. The next is a very familiar one. It is called chronic fluoride toxicity. The basic difference between acute fluoride toxicity and chronic fluoride toxicity is acute fluoride toxicity is a single consumption of a large dose of fluoride at a point of time, whereas chronic fluoride toxicity is ingestion of small doses of fluoride over a period of time. So this is what is manifested as fluorosis. The main cause of fluorosis is basically increased amount of concentration of fluoride. It may be maybe around 3 ppm or more than 3 ppm of fluoride in drinking water, and that taken over a period of time can result in a condition known as fluorosis. So the fluorosis can again be classified as dental fluorosis and skeletal fluorosis. The etiology of dental and skeletal is different because for dental fluorosis to occur, always remember the exposure should be during the time teeth are developing. So usually what is told is the birth period from birth of a person to 7 years age. That is the time by which the most of the crown completion of the teeth are completed except for the third molars. And if the exposure is during this birth to 7 years of time, it can manifest as dental fluorosis. Whereas unlike that, skeletal fluorosis can occur anytime when there is a long-term ingestion of fluoride for say around 15 to 20 years. So it is called as skeletal fluorosis. So dental fluorosis, the period of exposure is maximum up to 8 years. Usually it is 7 or 8 years. But when it is for 15 to 20 years at a relatively high concentration of 5 ppm, it results in changes in bone because bone is continuously getting remodeled. Skeletal fluorosis can occur later in life also. So that is the basic difference between the pathophysiology of dental fluorosis and skeletal fluorosis. So dental fluorosis is defined as a hypoplasia or hypomineralization of tooth enamel or dentin due to chronic ingestion of excessive amount of fluoride during the time teeth are developing. So always remember, during the time teeth are developing, there has to be an exposure to high amount of fluoride, and that usually occurs between the first 7 to 8 years of life. So when this occurs when it is more than 3 ppm in drinking water. ppm stands for parts per million. Does fluorosis occur in primary teeth? In the last video, I had told you that placenta acts as a partial barrier. Earlier, it was believed it is a total barrier. Now, it is believed that it acts as a partial barrier. So, if the concentration of fluoride ingested by the mother is high, to an extent, it can cross the placental barrier, reach the developing primary teeth in utero, and that can result in milder forms of fluorosis in primary dentition. The only difference is because primary dentition is already more whiter in color, it is not very clearly demarcated, but fluorosis does occur in primary dentition when the intake of fluoride is much higher uh, by mother. So these are various types or various degrees of dental fluorosis. We will discuss about the detail in under the chapter indices for fluorosis. But here just go through these pictures. These are the very mild types of fluorosis. This is the mild, this is the moderate type, and it can go up to this severe type where you can see even pitting along with stain. So there is always a criteria for differentiating fluorosis from other non-fluoride enamel hypoplasia, because this is the Russell's criteria for differentiation. Usually the area affected for fluorosis is near the cuspal tip or incisal edge, as you see in this diagram, whereas there is the other non-fluoride enamel opacities can affect any surface, especially the smooth surface. The shape of the lesion, you can see incremental lines in fluorosis. So if you observe this, you can see the incremental lines in fluorosis, whereas in non-fluoride opacities, it is just there is no specific incremental lines, it is only a round or oval shape. The demarcation, the fluorosis shades off to the surrounding, whereas your non-fluoride opacity, it is clearly differentiated from the normal enamel. The color is usually paper white, and it can also become, at the time of eruption there is no staining, it can later take a brown stain, whereas non-fluoride opacities is usually creamy yellow in color. The teeth affected are usually teeth which calcify slowly, whereas in non-fluoride opacities any tooth may be affected. And it is easy to detect fluorosis when the light is tangential, whereas it is easy to detect enamel opacities other than the cause is fluoride through a direct light, which is a strong light. So these are the basic clinical differences. You'll be learning about this later on once you come to the postings. So this is known as the Russell's criteria of differentiating fluorosis from other non-fluoride opacities. Next, finally coming to skeletal fluorosis, ingestion of high concentration of fluoride over a period of 10 to 20 years can result in skeletal fluorosis. These are few photographs of patients affected with skeletal fluorosis. And the signs and symptoms are usually there is a chronic fatigue, there is headache, dryness of throat, excessive water consumption, frequent need to urinate, urinary tract irritation, aches and stiffness of muscles and bones. And in all these areas, there is muscular weakness, muscular spasms, tingling sensation in fingers and feet. There is a continuous gastrointestinal disturbances. There is that is abdominal pains, diarrhea, constipation. Then pinkish red or bluish red spots on the skin, skin rashes, loss of mental acuity, depression, excessive nervousness. There is a tendency to lose balance. There is visual and temporary blind spots in vision. So all the systems are affected. There is a condition called knock-knee syndrome where there is a severe pain in the backbone and joints. There is an outward bending of legs resulting in the loss of shape. And there can be calcification of blood vessels, and there could be rigid and stiff joints resulting in crippling fluorosis. So this is what you see in these diagrams. So that is about fluorosis, and this is a map showing the distribution of fluorosis. We will talk about this in detail when we discuss about fluorosis and defluoridation. Thank you.